Hello, hello. Happy Thursday, everybody. Welcome to another version of Thursday VMR. Today, I'm thrilled to share the co-discussion seat with somebody who I've had the pleasure of co-discussing with 4 times now. Can you believe that? It's been four. If I'm counting correctly, it's been 4 times that we've had a chance to discuss together. But I may be off by one or two or three, but definitely not off by four. Um, I don't think oh, one sec. Sorry. Okay. I had a little annoying pop-up on my Zoom screen. I don't think Leah needs any introduction to anybody here. Leah's been part of VMR since almost basically its very origin. And as you all can probably know, the vast majority of us uh, will probably ebb and flow into VMR given our very busy schedules. But I think the most prominent thing about Leah is her absolute consistency and dedication to clinical reasoning. She's been here for so long in such a regular fashion and has become absolutely entrenched in almost everything we do in CP Solvers. You see her behind the scenes coordinating the teaching recap VMRs and actually was the idea generator behind that very that very initiative. I only recently learned, to my great embarrassment, that Leah is also playing a prominent role in the podcast arm of CP Solvers, which is definitely something that takes a long time to get to and shows um, her dedication to the space. But as I said to her before, I think my favorite thing is my interaction with Leah over WhatsApp. I think there's a very special talent to writing really good questions and reflections. And about once a month, I'd say, although it's been a little bit less than what I would like, unfortunately, about once a month, I get this like mind-blowing question in my WhatsApp thread, which I always need some time to reflect on and reply to Leah. But it's so cool to be able to continue to share this space with you. I'm excited for you to correct me on what number this is, if you know. And I'll pass the mic to you to say a quick hello before we introduce our case presenter.
Well, hello from my side. Thank you, Rabih, for this kind introduction. For those of you who don't know me, I'm Leah. I'm a medical student, soon graduating medical student from Austria. And it's just, I've been with the CP Solvers, or had the pleasure to be with the CP Solvers for um, quite a while now. And I just have to say that been such an enrichment, not just from what I could take away academically or learning wise, but just the interactions with all of you. I think every single one of you is inspiration to me, and I take away so many things also from my everydays, from the way you guys approach things and just hearing your stories. And yeah, I think the number 4 should be correct, but I didn't count, so it feels right. So it's
Let's just
about
say it's four. It's official now. Amazing. Well, I'm already excited for the fifth one, but the fourth will be special because I think I don't know if we've ever had a case presenter who's made such a prominent impact on VMR and their consistent presence. And I think all of you in the chat know Abir. Very excited for her first case. Abir, I'll pass the mic to you to tell us a little bit about yourself, please, before we jump in and learn from you.
Yeah. Hello, everyone. I'm Abir and I'm from Palestine. I'm thrilled to be here today to present a humble case that I observed in one of my training rotation to such a great platform for learning and teaching. A little bit about me that I'm graduated in 2021 and I'm currently working as a house officer in one of the biggest hospital in my country. Other than that, I'm just waiting for the match result. Yeah,
And
I
so
think
you
so.
applied this year, huh?
Yeah.
Oh my gosh, I wish you luck. I know it's near the finish line, a little bit over a month to go.
Yes.
Uh, so tell us a little bit about your work in the hospital. What do you do in the hospital?
Yeah, I'm working as let's say, as a general practitioner,
I see.
and yeah, in different department, including alongside medical team, surgery team,
I
OB/GYN
see.
team. So
Oh my God.
I'm yeah, I'm just not included to one department.
Yeah.
So yeah,
That
it's
must
like
be,
it's like a primary healthcare doctor. I don't know, something like that.
yeah. That's really cool. That must expose you to basically every aspect of medicine. That's really cool.
Exactly. Even that I'm applied to internal medicine.
Yeah. Did you think or consider any other specialties before you applied into internal medicine?
Yeah, a lot of specialties. Every specialty and every subspecialty,
Okay,
and
this is
even
your
minors.
is there a specialty you didn't consider? It's okay, don't worry. They won't be
Uh,
offended.
yeah, I think pediatric.
Yeah, I understand. It's really scary to be able to be responsible medically for a child. Yeah, I didn't consider pediatrics at all either. Um, Abir, what do you like to do outside of medicine?
Yeah, I love singing,
Oh,
specifically old Arabic
really?
song. Yeah, and I have
No way.
a nice sound to sing. Also, I love painting, even that I'm not a professional artist. I think it's a good way to make most of my free time.
Yeah. Do you
Yes.
have anything that you've painted close by?
Close by, yes. Give
Can
me
we
a
see it?
second.
Yeah, yeah, please. Oh my gosh, a
This
singer.
is one of my, by the way, this is one of my work.
Oh,
Yes.
really? Right behind you.
I think it's enough right now.
Yeah, no, my I'm from Lebanon and my mom would be very embarrassed, but I don't know how to read Arabic because I left Lebanon at a very young age. What does that say behind you?
It was a gift for my twin. I'm a part
Oh,
of Gaily twin. Yeah,
really? Oh
yeah.
my gosh.
So the meaning in English, I can say nothing can describe you and you are Jasmine. Her name is Jasmine, which is a type of flower. Yeah.
Wow. That's really special. Oh wow,
Yes.
that's really, really cool. Can I ask you, what is your heart rate now?
I
Still over
think
100?
no,
Yeah, there
decrease.
you
Yeah.
go.
Right
Yeah.
now, approximately maybe 70.
Okay, all right. We'll
70.
keep checking in,
Yeah.
okay?
Yeah.
Don't drop too low, okay?
Yeah.
All right, Abir, we're
Prepare
ready. Yeah.
atropine. Prepare our atropine, intravenous atropine
You got it.
to keep in our mind,
All right,
just
Abir.
in case.
We're ready whenever you are, armed with atropine.
Yeah. So let me know when you would like me to start.
Yeah, go ahead, please.
Okay. Um, I have 5 aliquot before the final diagnosis.
Hmm.
So let's start. Chief concern, difficulty breathing for 1 day.
Okay, so I will just start. And let's just say I'm always the most nervous before I hear the chief complaint because that kind of it's like what will be the chief complaint we'll be discussing today. And it seems like it's difficulty breathing. So my mind translates that to dyspnea, as the term we often hear difficulty breathing since 1 day. And 1 day is already very helpful because it gives us a time course and makes it even more concerning and makes me wonder what happened 1 day ago. Why why so sudden? Was it really that sudden in onset? And then difficulty breathing, we have the classic dyspnea causes, we think lung, cardiac, then metabolic, anemia, metabolic acidosis, and then other causes. But I think with this basic frame that we have, it's really hard to say which direction this is going in because difficulty breathing is already very subjective, what the patient is saying. We want to objectify what is this patient hypoxic, where is it only with exertion or without exertion, and who is this patient in general, so that I can get more of a feel of how serious we have to take this. But definitely already the acuity of the onset kind of makes me think of, oh, maybe we also have to act fast because this came.
Yeah, I completely agree with everything you're saying. You're teaching us, Leah, that you're translating difficulty breathing into dyspnea and you're using your dyspnea pyramid. And I think the most powerful filter that you're applying to that approach is the time of onset. I couldn't agree more with you. We have to diagnose this condition in proportion to its onset. The faster the onset, the faster the need for a specific diagnosis to treat it. And I think that if you sort of zoom in on one aspect of that specific aspect and try to predict um, uh, uh, what you might find subsequently, whenever somebody reaches the threshold of clinical symptoms pretty quickly. So if we just use this as visual, as like this is the threshold to become symptomatic from whatever disease, if somebody reaches it and goes very quickly from a subclinical threshold all the way up here, you wonder one of two possibilities. Did they arrive to this threshold so quickly because they were just under it one day ago? They were just subclinical, and then all it took was one extra day of symptoms to notice that actually they're short of breath. Or did they begin at normal and have a super accelerating disease process? I think it'll be fundamental in the next HPI to try to establish what the patient's baseline is, because the opportunity to diagnose a subacute but subclinical presentation until day -1 might be lost if we make the assumption that the more acutely sinister hypothesis was the patient began from normal breathing to pathological breathing. It is totally possible that the patient does not have normal breathing, but has subclinical pathological breathing. And questions to understand that are going to be key, especially about exercise tolerance. So what's the summary here? The summary is it's going to be really important to know the distance that the patient was from the clinical threshold, because there's only really one of two possibilities to reach the line of clinical threshold so quickly. Either you were very close to it, but you didn't realize, or you have something that propelled you from normalcy into pretty serious conditions. And trying to get a lay of the land of which one is at play can only really be established definitively on the HPI with listening and asking good questions. So for me, the first question I would ask is, okay, tell me what you were able to do and accomplish 2 days ago. And that, I think, is the question I really, really want to get right before we go down the tunnel of solving the problem. All right, Abir, tell us more, please.
That's amazing. Okay. A 77-year-old female present with a 1-week history of a progressive productive cough, 3 days of fever, and 1 day of feeling breathless when she tried to take a deep breath. She also reports more chest pain, particularly during coughing, and has noticed greenish sputum. Also, she experienced general weakness and decreased appetite. There is no history of recent chills or night sweat, no recent history of hemoptysis, no orthopnea or paroxysmal nocturnal dyspnea, no nausea, vomiting, abdominal pain, bloating, or a change in bowel habit, no rashes, lesions, or changes in skin color. But worth to mention, 2 months ago, she was admitted as a case of disseminated VZV, and since discharge, she complained of persistent weakness and decreased appetite. And I will stop here.
Okay, thank you, Abir. So with this new history, we know that there was a history before this presentation a day ago. And I'm still kind of, I find it still hard to see how the difficulty breathing fits into this 1 week history. Then did she say she really started to notice a drastic increase in difficulty breathing a day ago?
Yeah, she started complaining of difficulty breathing just 1 day ago. Before that, just coughing and chest pain, pleuritic chest pain, we can say. Yeah.
Yeah,
and
thank you. So with this history, we have quite a relatively acute history of productive cough, pleuritic chest pain with the green sputum, and I think many of us would associate this with a pulmonary process. Probably this could be a very typical presentation of pneumonia, for example, if we could correlate this with a chest X-ray, and then see in this female, she doesn't have fever. That doesn't change too much for me, especially older patients. They might not always present with fever, even though they have an infectious process. But I would prioritize an infectious process here because of the acuity of the onset and the green sputum and the picture the patient presents with. We don't really get a cardiac aspect with the symptoms here yet. The pleuritic chest pain does make me think more of the pleura. There might be a pleural involvement here as well. So I'm wondering, might there be, because it's progressive, she had this cough, and now it's progressing to dyspnea. So how was she treated? Did she receive treatment? Or is there a complication or progression of whatever process is going on? So that's what I'm worried about, because I translate the dyspnea to progression now of whatever has been or was going on before. And then she also describes as persistent weakness, which in this case, I would translate to asthenia due to the illness this patient has. We don't get any neurologic flavor just yet. And disseminated VZV last month. What does that do for me? I think especially disseminated means the immune system cannot keep control of the disease. So makes me worried about, is there any predisposed immunosuppression? And I think I won't go deep into that, but we can then start to activate our schema for immunosuppression in the older patient and think what might be the background. Perhaps Abir will give us more information as we go on, but I would definitely want to know what kind of complications did she have? What does disseminated mean for VZV? And then go from there.
I have nothing to add to your superb reflections, Leah. I think that it's interesting, though. I'm surprised by what we found. I'll share with you more insight on the onset of 1 day. Most people who have onset for 1 day, we often are activating our hyperacute schema, but often what's really happening is there's a subclinical vulnerability. And for most patients with a subclinical vulnerability that presents with shortness of breath, they have a subclinical anatomic vulnerability in their cardiopulmonary apparatus. So they have COPD, bronchiectasis, heart failure, coronary artery disease, so on and so forth. Many of these conditions are chronic. All of these conditions, COPD, bronchiectasis, coronary artery disease, and heart failure, all of them are chronic. And then they have really acute, devastating versions of themselves. CAD causes MI, heart failure causes acute decompensated heart failure, COPD causes exacerbation, and bronchiectasis flares up. And so when you're healing 1 day, the bets are you're going to find some subclinical vulnerability. But here, that subclinical vulnerability does not have the phenotype of a structural disease in the cardiopulmonary system. It seems to be an immunological vulnerability. Now, how confident can we be that the patient has an immunological vulnerability? I would say probably pretty high. It's very unusual to have disseminated zoster, period, let alone to have disseminated zoster followed by a intercurrent, presumably infectious syndrome. So it goes to show you that hyperacute can mean true hyperacute, but often hyperacute means, why is this person vulnerable to getting so sick so quickly? And I think we found a lead to explore, and that's the immunodeficiency, or the presumed immunodeficiency. But as you alluded to, it would be premature to start to dive into that until you know more. And some very simple things on the background data to help you stratify immunodeficiency is, of course, the age of the patient, but some very simple things. Do they have immunosuppressive medications in their medical history? And something we don't have space for on the whiteboard because it doesn't come up, but it's really important, is vaccination history. And if we learn that she hasn't gotten her zoster vaccination or her pneumovax vaccination, then that may be the end of it. So I think for me, I'm there with you trying to confirm our suspicion that this is a pulmonary or pleural infection open to something else. And I think a simple glance at the meds and vaccination history is going to be really important in the next set of data before we move on and get fancier in the world of immunology. All right, Abir, tell us more.
Okay, amazing. I love the discussion. Okay, for the past medical history, she had the malignant thymoma, which is resected in mid-2022. Myasthenia gravis, treated post-tumor resection. Asthma, mild asthma, which is treated by nebulizer as needed. And she also had a history of recurrent hospitalization for severe COVID-19 pneumonia and disseminated VZV, skin VZV. And I would like to share a screen for her, a time course for her admissions. Can I share my screen?
Go for it.
Thank you. Can you see my screen now?
It's loading, yes.
Okay, here we go. As you can see, she had frequent and repeated admissions
Wow.
like COVID infection and pneumonia here, pneumonia and other pneumonia, and for herpes zoster and pneumonia.
Mm-hmm.
So yeah, I would like to show
Yeah.
you
Thank
how
you.
she has a recurrent hospitalization.
This is
Yeah.
amazing. This is above and not surprising, above and beyond. An artist representing medicine in a very simple way. Thank you very much.
Yeah. And I will stop here.
Okay, all righty. I think your thoughts are bearing fruit, my friend. What are you thinking now, Liam?
That was a lot of actually it was just the past medical history, but I feel like it was a lot of information. Sadly, this patient had a lot of admissions in the past years, and I think this just underlines the fact that we considered immunocompromised state because of recurrent infections that this patient has, and also gives us more lever to their might. One, it made me think of two things. One, what is the underlying vulnerability, why this patient gets so many infections, also with the pneumonia. And then two, there might already be like a structural even predisposition because of the recurrent infections that this patient had. But how to tie in the malignant thymoma into the whole history? The only thing I had, because I was wondering why this kind of getting acute or more acute with the breathlessness, was there kind of a hit, like in form of a PE or something else that might might have exacerbated everything? And I was thinking, is there maybe a tumor history or malignancy that also increases the risk of pulmonary embolisms? That's the only thought I still had connected to that. Other than that, I think I would just now really want to go on and find out about the immune state of the patient and how and their ability to fight off infections.
Superb. Very, very well said. I love how balanced your reflection is, including the dimensions you want to proceed and also the question marks you have about connecting thymoma to our current state. I'm deciding how much to say now, and I'll just be transparent with you. With a lot of work and a lot of reading and exposure, which all of you are doing by virtue of being here, you can come to suspect a very rare but important condition with just the information you have right now. And I want to put in the future, I'm trying to put a pin in these moments because it's not clinical reasoning isn't just about getting the diagnosis right, it's trying to get it as efficiently and effectively as possible. So this is a moment where we might come back to where the history, the combination of everything we're hearing makes us wonder about something that's really important to consider and may make your arc efficient. So let's just put a pin in this. But I think the real thing that has happened, Leah, is that we have now, I think, looking at that history, confirmed that we're on the hunt for an immunosuppressive condition. And I just wanted to articulate the caution that I think we were both having earlier, which is that age alone is a sufficient explanation for a presumed pneumonia, and age alone is a sufficient explanation for disseminated zoster if nothing else is found. Now, the question is age alone sufficient for the combination of both? Probably not. Is age alone a sufficient explanation for all the things she's experiencing? Definitely not. So how can we have a structured approach to immunodeficiency in an adult? And I will emphasize that looking in the patient's background is really important. Meds and immunosuppressive meds and vaccinations is key. But also careful attention to a variety of organ diseases we tend to ignore. Patients with cirrhosis have a high rate of immunosuppression. Patients with kidney disease have a high rate of immunosuppression, chronic kidney disease. Patients with diabetes, so on, COPD. So many metabolic conditions mess up with the immune system, either through glucose toxicity or the many reasons that the cirrhotic factors impair macrophage function, so on and so forth. Um, one one feature that I think is really easy to start to look for in your laboratory data is a hematological fingerprint of immunodeficiency. So a very simple combination of two tests, a CBC and a SPEP and immunoglobulin analysis can help you a lot. What we might look for on the CBC is to look for a macrocytic anemia suggestive of myelodysplasia, which commonly features immunodeficiency, and the immunoglobulins, we're looking for immunoglobulin deficiencies. But I want to make one really important point about how you go about that workup is you're trying to understand what cell lines might be affected. It's helpful to stratify immunodeficiency as extracellular immunodeficiency or intracellular immunodeficiency. And immunologists have a much better way of using the terminology, but that's how I use it. Is the immune system dysfunctional at killing extracellular organisms like bacteria or molds? Or is it dysfunctional at attacking intracellular organisms like viral infections and granulomatous diseases? So if you track a classic example of a lymphocyte depletion syndrome, when lymphocytes are depleted, you get predominantly disseminated infections with intracellular organisms like VZV or granulomatous infections. If your neutrophils are impaired, like in neutropenia from cancer, you're mostly going to get bacterial and fungal infections. Now, what's really, really interesting about this case so far is the patient has a combination of both. She has features of bacterial pneumonia, extracellular organisms, and features of course, disseminated viral infections. So if she has an immunodeficiency, she has an immunodeficiency that crosses this division of extra and intracellular organisms, which makes it a particularly severe one if she were to have it. So two pieces of advice here. Pay close attention to the subtle labs that are often given, the CBC and the immunoglobulins, but also ask yourself, am I dealing with an immunodeficiency of extracellular organisms, bacteria, and fungi? Primarily think neutrophils, or are you dealing with an immunodeficiency of intracellular organisms? The most common immunodeficiency that causes both is HIV. HIV impairs your CD4 cells, causing lymphocyte depletion, but also impairs your B cells, reducing your immunoglobulin secretion, impairing your ability to fight bacteria. All right, Abir, tell us more, please.
Okay, yeah. For physical exam, she looks fatigued and tachypneic. Vitally, her temperature 37.9, normal blood pressure, normal heart rate, SpO2 88 in room air, so she required nasal cannula 2 to 3 liters. For physical exam, head and neck normal, no lymphoadenopathy or visible dilated vein. Heart normal S1, S2, no added sounds or a new murmur. Lungs diffuse wheezes, and there is right-sided decrepitation until the middle zone. Extremities mild lower limbs edema. In neuro, good power and tone, no, and there is no sensory deficit. And her initial labs showed us white blood cell 11 with a neutrophilic predominance, hemoglobin 11, and MCV 88, and the platelet count was 250. C-reactive protein was 24, normally less than 0.1, and normal electrolyte, normal creatinine, and albumin, normal AST, ALT, and bilirubin also normal. So yeah, just give me a second. Hair imaging, chest X-ray and CT scan. I would like to share a screen again. Okay. Can you see my screen?
Yes. Yes. Wow.
Okay. Yeah.
What jumps out at you, future radiology, well, current radiology rotator?
Um, so it's funny because I'm on the radiology rotation. This is gonna be a good training now. Okay, so we have this chest X-ray, and then I will try to say a few things that come to mind. One, I look. Okay, I have to take the image closer. So definitely, I'm not going to do all the structured approach, but just what is very into the eye at the moment. One, we have these infiltrates, which look to me bilateral, but I also think it's probably not such a good inspiration. So the lung might be a bit higher up, which makes everything looks denser. But still, there is definitely something, especially I see something on the right side of the lung laterally. And then also on this side, I cannot exclude a pleural effusion, whereas on the left side, it does look like the claustrophrenic angle looks more clear to me, at least from this perspective. And then what is also weird to me is the size or the shape of the heart, because I don't expect it to go that far to the right side. So that is also kind of concerning. I would want to know, is this the heart, or is there infiltrate in front of the heart that just makes it look like the shape of the heart extends more towards this direction? Definitely very diffuse, and that's why I also find it hard to differentiate. Is this congestion also, because I cannot see the hilar regions that well to kind of evaluate that component, but I would say hence infiltrate on both sides with definitely a patient post-surgery with the sternotomy
Yeah.
things you can see in front, and then also the ECG devices you see on the in front. And I'm wondering if these are drainage things, the round things, but they look a bit odd to me. Maybe it's on the outside. Never mind. I think definitely we have to I would get further imaging. You already said you have a CT. Oh yes, to further evaluate that. And here we have this, I would call it consolidation on the right side of the, or in the right lung. And already, and I'm no radiologist, I'm just saying what I see, so maybe it's not right, but there's definitely something there, consolidation too in the right lung. And then also on the left side of the lung, it almost looks emphysematous aspect, like the darker, more transparent things, but there's something there and I need help.
You don't need help, my friend. I think that's an absolutely superb read. I completely agree with everything you say. I think if I were to talk, I would just be repeating what you say. It's amazing how much more predominant the infiltrate on the CT is on the right than the left. I'm really glad there isn't a pleural effusion. I think that would have really raised concern. There's a small effusion on the right for sure, compared to the left, but it's not that impressive. It's mostly a parenchymal opacity. All right, Abir, give you the mic for. Oh, actually, you wanted us to discuss this section, right? Sorry.
Okay. No, it is. You said what I want to say.
Yeah. All right. Perfect. All right. Why don't you give us some more the next round of data?
Okay. Here sputum culture was positive for streptococcal pneumonia. Also, yeah. I will stop here because the next ELIQUA will be the final ELIQUA before the final diagnosis. So would you want me to continue or stop here?
Oh, let me just clarify really quickly. So, Abir, you have one more set of information that will
Yeah, before the
digest.
final.
Okay, yeah. Why don't you tell us that, and so we can reflect on
Okay.
that and maybe spend some time at the end.
Okay.
Have maybe save some extra time at the end. So tell us the final information before the diagnosis.
Okay. As we can see, we admitted the patient to treat her lung infection but we also admitted her to investigate the cause of her repeated infection and frequently admission for her previous infectious diseases. So we consulted immunologist doctor, and further investigation showed us HIV negative, HTLV1 negative, and her serum immunoglobular levels, IgG 215 milligram per deciliter, IgA 43 milligram per deciliter, IgM 24, and her immunophenotype of peripheral blood showed us low score of lymphocyte 10% with abnormal ratio B, T, and natural killer cells, CD19 and CD20 2% only, and there is abnormal ratio of CD4 to CD8 ratio less than 1. Yeah, and I will
Well,
stop here.
thank you, Abir. This is really, really helpful. Can I just clarify, while Leah thinks about this, can you give us a sense of the units? Are the IgE, which one of the IgA, IgG, or IgM are low? Are they all low, or is it
Yeah,
all of
hypo.
Yeah, there's panhypoimmunoglobulinemia, which I never thought I'd be able to say, but I'm feeling calm today. All right, Leah. Yeah, I'll just qualify this by saying that there is no way that even a graduating internal medicine resident will analyze this data with confidence. So I think you're going to have to lean on analogical reasoning and using the knowledge that you have. But that's the fun part about learning. You're always going to get more juice out of it. So take a crack at it, and then we'll just have a conversation.
Okay. Well, thank you for the information, Abir. It's also very helpful to know what the units are. And I will just say the first two associations I have with these numbers and then what kind of conclusion I draw out of it. So hypoimmunoglobulinemia, and I also said it out loud, is I associate that with common variable immunodeficiency syndrome, which is, I think, the most common group of immunodeficiencies. And from what I know is that you have to have a low IgG and IgA and IgM also included. And you make this diagnosis by, one, finding this result on labs, two, also excluding other causes that might lead to this. So it's actually a diagnosis of exclusion, if I'm not wrong. And then also these patients typically don't respond to vaccination. So that's also a clue. And it's very typical that they have recurrent infections, which also fits with this patient. Now, I think where I have to stop is I cannot confidently make this diagnosis because I cannot exclude other things very confidently. But the second associations that I might have is the CD19. Isn't that some kind of T lymphocyte marker? And again, I'm not 100% sure about that, but there's definitely a lymphocyte that is low. And it's also indicated with the abnormal ratio, which is the CD4 and CD8, which is also a T lymphocyte marker. And what does this tell me? There's an abnormally low level of a lymphocyte population, which makes sense that causes, or it could cause an immunocompromised state, but then we also have low immunoglobulins. As Rabih, you alluded to before, immunoglobulins, they are made by our B lymphocytes. So we kind of have a problem with both the T lymphocytes and the B lymphocytes. Now that's where my the power of my knowledge and the analogical reasoning ends. And I just have to say this patient has an immunodeficient state because of compromise in both the B and T lymphocytes. And I would have to go and ask Rabih how to continue from here.
Leah, I think your analysis is absolutely superb. The way that you were able to localize the lesion to B lymphocytes because of the deficiency in their products, and that triggers the robust association with common variable immunodeficiency. And that association should be a strong one because it is in fact very common, hence the name common variable immunodeficiency. But then you realize, wait, hold on. This patient also has a deficiency in their T cells. And that deficiency is very prominent. So now you have to be like, what's causing B cell deficiency and T cell deficiency? And a prominent T cell deficiency is inconsistent with the diagnosis as common variable immunodeficiency. I'm really, really like bursting from the inside because I want to share with you a schema for immunodeficiency, but unfortunately, powers above me mean that we have to keep them for just RLR-CP solvers. So if you have access to RLR-CP solvers, please, please, please go check it out. If not, you should really consider subscribing. There is a big student discount and a big IMG discount, but I think we have enough time, which I'm very grateful for, Abir, to actually go into breakout rooms for you all to chat amongst each other for a few minutes, because I think this is one really, really educational case that Abir is presenting. I don't think we've had an immunodeficiency centered case ever on VMR. So I think the more you all chat, the better, and then we'll come back and Leah and I will kind of share our thoughts out loud. Okay. All right. So see you all. Please, if you're unable to go to the breakout room, just hang out. But I really, really encourage you to if you are able. I think it'll be a lot of fun. All right, welcome back, y'all. I hope you had a really nice conversation in your room. I'm curious, Leah, what was your conversation like, and what additional thoughts or clarifications or questions came up for you?
So yeah, we had a really nice conversation with Anmo and David,
Yeah.
and it was only a small fraction was then actually about the case, but I think that we conclusion and found a diagnosis that was quite a good fit,
Yeah.
unintended. And apparently there's a term called, or a syndrome called Good syndrome, which is an immunodeficiency that is associated with thymoma as well and affects both B and T lineages. And I think it's a term that I had heard before, but my only association was immunodeficiency. And I just mentioned that it was one of the terms where we studied for exams, and there were too many slides, and it was one of the less important slides. So now I'm glad to kind of get it back and get to know it more. But that's, I think, the conclusion we came to in our group.
Yeah, I couldn't agree more with you. I think that's a superb conclusion. I decided I can't resist the urge not to show you the picture. So I think I can cheat a little bit and pause the recording and just have a conversation with you all, and then we'll resume it real quick. So sorry for those of you on YouTube. Yet another incentive for you to join VMware Live. But let me present with a combined B and T cell deficiency. So when you're thinking about low immunoglobulins, your reflex is to think CVID as you did, Leah, because it's the most common cause. But if you're structured and systematic about it, you'll review the medications. You'll consider a hematological malignancy that is accompanied by deficiencies in immunoglobulin secretion or the non-selective loss of immunoglobulins, non-selective through the skin, the GI tract, or kidney. But yeah, put a pin in that moment. The moment you have immunodeficiency and thymoma, that the possibility of a good syndrome can cross your mind. And it's very, very, there are things you can do to help the patient. So it's a very actionable thought. So kudos to you for the brain power to get there and to localize the problem. And I guarantee you, Leah, with the information that you were able to deduce, if you just Googled low B cells, low T cells, and like thymoma, you would have found the answer. And then that goes to show you that if you understand the problem, you'll need much less assistance to figure out the solution. But Abir, I'll hand the mic to you. Hopefully we're on the right track.
Yeah, I'm proud of you guys. I'm proud of you guys. You nailed it. Yeah, considering her previous past medical history of thymoma dissection and her repeated and frequent infectious diseases, her condition consistent with good syndrome. So yeah, you nailed it.
Abir, tell us, how was it like to be involved in this patient and take care of her? What did you learn?
Yeah, I taught a lot from this patient because it was my first time encountering Good syndrome patient, and which was quite different from what I was expected in thymoma patient. I always associated with myasthenia gravis, but this patient showed me it could be associated or linked with other autoimmune disease and condition like myasthenia gravis, other than myasthenia, like pure red cell blood aplasia, or
Yes.
could sometimes diabetes or Pernicious anemia and other autoimmune disease. So yeah, and I would like to share some, let's say, some high yield point about Good syndrome with you if we have the time. I don't
Yes,
know.
please, of course.
Okay. Um, Overall, Good syndrome is a rare adult onset immunodeficiency characterized by thymoma and hypogammaglobulinemia. And the immunodeficiency may proceed or occur after the thymoma. We diagnose the thymoma. And until now, we don't have, let's say, the exact or the pathogenesis of Good syndrome has been incompletely understood until now, but there are several hypotheses that may explain this. Some of these may be due to some protein or cytokine produced from the bone marrow that will inhibit B cell and T cell precursor differentiation and maturation. Other theories may be due to from T cell itself that produced from thymoma may inhibit B cell from producing immunoglobulin. Also, we don't have, let's say, clear criteria to diagnose Good syndrome, but based in, let's say, in different published cases or articles, I, I want to share my screen to show you schedule. Yes. Here. Yes, we can see it. You can see, yeah. Can you see my screen?
Yes.
Yes, okay. Yeah, here. Okay, this is the possible immunological finding that we may see in lab finding. And this was reported in 75 cases of Good syndrome. As we can see, all of these patients let's say, have low level of serum immunoglobulin and low number of, most of them, low number of B cell, and also uh, I will say the most significant finding and low number of, let's say, low ratio CD4 CD8 ratio, which namely called inverted CD4 CD8 ratio. And I think this is a good point to mention. Inverted CD4 CD8 ratio, when the CD4 CD8 ratio less than 1, which indicate, let's say, um, immunocompromised or defect in immune system. Yeah, so these are we can consider these criteria to diagnose Good syndrome from immunological finding in lab test, panhypogammaglobulinemia, low or absent number of B cell, and inverted CD4 CD8 ratio. Yeah. And regarding the treatment, I think we must mention that. As we all know that most of autoimmune disease that associated with thymoma, we treated with thymomectomy. But unfortunately, Good syndrome, let's say immunodeficiency that associated with thymoma doesn't improve with thymomectomy and even may worsen the hypogammaglobulinemia. So the cornerstone of the treatment will be IVIG, monthly IVIG. So yeah, and this make a difference for most of the patient. Yeah.
Absolutely amazing presentation, Abir. You told the story in such an engaging way, and the slides and your teaching at the end is just absolutely superb. I really hope you've enjoyed um, presenting your first case, and I hope you have many, many more to share with us. Thank you so much. This was a real treat.
Thank you, Rabih. Thank you, Leah, and thank you all. Yeah,
Our pleasure.
I enjoyed. Yeah, and I learned a lot from your discussion, and I love the discussion in each point. So thank
Thank
you all.
thank you so much. Leah, what was your reflection? What was it like to discuss this case?
Oh, I think it's such an interesting case. I think immunology is so
Yeah.
interesting, and I loved So thank you for bringing this case. And I think this is also just a great case that illustrates how we should not just see the current presentation, but the context the patient presents in. Because we could also have seen this as the patient with pneumonia, but then there was so much more behind that to explore,
Right.
and then definitely much to read about Good syndrome, and
Yeah.
loved also this division of extracellular and intracellular immunodeficiency. Yeah, so thank you for the
Oh,
opportunity to get to
yeah,
discuss.
I think that number 4 was a really special one. I thought you were absolutely superb in your ability to make progress and also articulate the parts that you didn't know. And then you put your brain power together with colleagues and essentially got the answer, which was really, really cool. So kudos to you. And I'll pass the mic to Marino to take us through the teaching point.
Hello, guys, again. It's been a while since I've been in the teaching point seat, but it's good to be back. Thank you for the case, Abir, and thank you for the amazing discussion, Lee and Ravi. So let's get started with this. So right off the bat, we got a patient that had difficulty breathing, and difficulty breathing, as Leah said, is something sometimes very subjective. So sometimes we have to look for objective things, and simply asking a question whether is it with recession or not, it can be very helpful to differentiate between entities. But also we should look very quickly for the onset, because as Ravi said, the faster the onset, the quicker we have to make an intervention. So other questions we can ask to a patient that has shortness of breath, and when we try to look for the onset, we must look for the baseline status of the patient. And a simple question such as, tell me what you were able to do and accomplish 2 days ago, can help us differentiate between the onset and whether the patient had or not any symptoms before being presented with this acute situation at the moment. So when advancing the case in the HPI, we got that the patient had dyspnea plus productive cough and also pleuritic chest pain, something that kind of makes us shift our thinking towards a pulmonary process. So even though the patient didn't have a fever, we still cannot rule out an infectious disease. So when we were advancing on the discussion, we saw that the patient had disseminated zoster, and this is something that is very rare, but being present in the state of disseminated zoster shouldn't make us think immediately about immunosuppression. We still have to look for other causes, such as we should dive into the medication history, the age of the patient, vaccination history, or other chronic conditions that could predispose to being affected with infectious diseases such as diabetes, cirrhosis, and COPD. So when advancing into the case, we saw that this patient was presenting with recurrent COVID infections and also the disseminated zoster. So when trying to think about immunodeficiency, we can divide it into 2 simple ways. So think about extracellular and intracellular organisms. In extracellular organisms, we think about bacteria and mold. So when this is present, we think about more of a neutrophil deficiency state. And when we get intracellular deficiencies, such as diseases such as viruses and granulomatous disease, we must think more about a little bit lymphocyte depletion. So if ever both of these are combined and we have to think of one of the most common conditions, we have to think about HIV. HIV impairs B cell signaling and also depletes our lymphocytes. So mostly every patient we get with immunodeficiency, we have to test them for HIV. After reading the lab results, we got that the patient had hypogammaglobulinemia. So the reflex is to think about CVID right off the bat is probably the most correct choice that we can get, but we need to know that it's also a diagnosis of exclusion. So we must rule out other entities before thinking about CVID, such as look for the medications, see if the patient is taking any steroids or rituximab, look for malignancy, such as this patient that had thymoma, and also look for causes of protein loss, such as burns, protein losing enteropathy, cirrhosis, etc. So when we were arriving into the end of the discussion, we made the tie about this patient having a thymoma, having hypogammaglobulinemia and also having T-cell deficiencies because of the infections she were presenting. So we ended up to knowing the diagnosis of good syndrome, because thymoma plus B and T cell deficiency means good syndrome at the end. So another pearl that I didn't know was when Avir shared to us that getting out the thymus, doing a thymectomy, doesn't improve the immunodeficiency. So basically, these patients are treated with IV immunoglobulin. So thank you for everything. Feels very nice to be back and being involved with the CP Solvers again. And thank you for everything, guys.
Outstanding. It's like you never left, my friend. That was absolutely superb walkthrough. I know you've been lurking in the background for many, many VMRs, and it's really excited to hear your voice and articulate the teaching in such a logical and a clear manner. The answer was good, but your teaching was great, truly. And thank you, Shreyas, for scribing, and Abira, thank you again for an awesome case. And Leah, I already look forward to the to rounding out the discussion with number 5. Have a good day, y'all.
See you soon.